Hello, good morning. My name is Marek Dąbrowski. I came from Poznan, Poland. I'm working in huge medical simulation center. I'm an educator, but also my background, I'm paramedic. Right now, my role in our medical university in Poznan, in our also medical simulation center, I'm working with students, but actually second part, I'm preparing my new teachers how to teach students, how to use simulation, how to use that different techniques and method to create not only scenario, but actually all classes, systems, schedules, and how to perform the program and put into simulation. I will focus of the perfect simulation, and I would like to show you high fidelity scenario, what it's mean, and how we can prepare of that, and what kind of strategy and plan we can organize before, what we need to prepare before we will start thinking actually about simulation scenario in a sim center or a simulation scenario with in situ simulation. There is no conflict of interest. I'm representing also Polish Society of Medical Simulation. I'm president of that society in Poland, but right now I will focus on high fidelity scenario. The first question is actually why we want to use it, high fidelity. The beginning is like we have low fidelity simulation, and this is some kind of part of workshop when we would like try to teach some intervention, simple protocols, simple things, simple tools, simple task, and we will practice on simple dummies. But if we will pack everything into higher realism, then we will create some realistic environment with or for team of some couple person around, and then we would like to create more high fidelity scenario with realistic environment. Why is that important? Because if we practicing and making something with practice, we increasing levels of simulation fidelity, then our action and also the bridges in our brain will be more inside, and participants will remember longer. If we will only talk, if we will only show, if we will only give the books and tell, please prepare some kind of pages, it's okay, we're building the knowledge, but if we're practicing, we will remember older, longer. Always, if when we like creating some realism, from my perspective, I want to create that part that between education area and clinical area will be some kind of bridge, and that will be like fluent way to achieve the learning objectives. But very often we actually seeing some kind of situation like here, people from education area want to prepare general rules and show the guidelines, but in the clinical life we're focusing of some specific things. What are we doing right now here in that hospital, in that ward, in that department? And very often we can hear the question, what do you have before, who teach you, or something like that. And it's good if the practitioner will be also educators. On the beginning of that way, we all the time first need to think about learning objectives. If I want to create any specific scenario, any lecture, any workshop, any meeting with students, and I will teach my students anything, all the time, first question is what I want to teach, what kind of goals I have, what kind of learning objectives I want to achieve, and then if I'm thinking about some learning objectives, it's good to think about that should be specific, measurable, achievable, relevant and realistic, and also in proper timeline. First of all, we will teach, for example, like here, cannulation, then we will make some priming with equipment, then we will show on other devices and we will explain everything. And after that, when we will be sure that everything is done, we can make high fidelity scenario. If I will start with high fidelity scenario in the beginning, but even one person in a team will have not the proper, not only knowledge, but experience with devices, with equipment, and with some kind of method, suddenly our scenario can stop, because that will be like the huge challenge for someone in a team. Not all the time. Proper timeline, and in proper time, when we will put specific part of technical skills, and also we will focus on non-technical, then I can add everything, connect, and create one scenario for my team of participants. 5 really important questions. Who will be in my class? For who I have my course? For who I will make that specific scenario? Usually I want to know who will be my participants. And then I will prepare. If there will be a team only in scenario, and scenario will be only for physician, I can switch some couple things and prepare only for physician. If I will work like by ECMO team with nurses, with physicians, and also with perfusionists, that I need to create some specific area and think for who is which part in that scenario. Then what I want to teach, what I want to create, what kind of scenario. Then what I want to do is like when we're making some trainings, even in our sim center, normally we're working by week with students, and then on weekend we spending time very often postgraduate, because in normal days like between Monday and Friday we don't have enough space for some postgraduate trainings, but after Friday evening and Saturday and Sunday we have a lot of space to teach some healthcare professional postgraduate, and this is the proper time of that. Where I will teach, what kind of equipment I will have, what kind of specific rooms, what kind of dummies, devices that I'm prepared, or I need anything else, what is needed for some specific scenario what I want to create. And actually the last thing is like how I want to teach. How much time I will spend for low fidelity simulation, and how much time I want to spend in some specific realistic high fidelity scenario. And after that, if I'm creating some session, usually the simple strategy, but this is not so simple, it will be like introduction for my participants. Like every time on the beginning, we just hear that Justyna explain what we will do on our workshop here. And this is actually some introduction. How much time I will spend, what kind of knowledge, what we will do. This is a program, our schedule, everything on the beginning. And after that, pre-briefing. If we're thinking about pre-briefing, this is some specific time to prepare our participants, our students, to be more familiar with any devices what we will use during our training. If I will ask, like by ECMO, who working with, for example, Xenios, who working with cardio help, and then I will have like half and half participants, but in my sim center we have only one example of that device. We need to explain for everyone how we will use that equipment and what I want to achieve. That's pre-briefing all the time will show us or will give us the time to explain also our participants. For example, if we're recording our scenario, we need to inform participants cameras are working, and also the teacher will be behind the Venetian mirror, for example, and will watch scenario, but will be not with you inside high fidelity scenario, with you inside the room with a patient. This is that equipment. here we have that kind of devices, and we need to like prepare to be, like I told, more familiar with that everything. Then we have scenario, and after that we need to think how I would like summarize it, how much time I have after scenario to discuss about what happened. If I have like a really short time, 10 minutes, because I need to run and start with next scenario for next team, probably we will focus only on the feedback, and we will give feedback our participants. But if I have like more time, more minutes, we can discuss longer, and I will explain the differences between the classical debriefing and also like feedback when we're using that method. Simulation. We need to keep the goals all the time. Like learning objectives should be all the time in our work. If I'm thinking about design scenario, I'm thinking about the goals. Then if I wanna do pre-briefing, I need to focus also about the specific devices because I want to achieve my goals in that scenario. But for my students, that will be a task, not the goals. About the goals we will discuss with students in scenario. Then is brief of the problem. I need to explain if I have low fidelity simulation, and for example, we will cannulate, I will give the task. Please make some cannulation. But if I want to create high fidelity scenario, I will explain. You have 48 years old male with that problem. He spent that time in a hospital. His previous problem was in SBAR. It will be situation, background, assessment, and we have some kind of recommendation. And your rule is you're a team of. And then I will ask, do you need any time to divide the roles in the team, or you want that I will divide you? And I'm waiting actually for an answer, and then, okay, it's just started. You have, and that depends. If we want to create like 1 hour, we can spend 1 hour. If we have only 15 minutes, we will make 15 minutes. But if we will use like more realistic equipment and also prepare some environment for non-technical skills for teamwork, communication, and everything will be like realistic, then we are really close like in normal clinical life. And this is very important to think about that high fidelity things. Scenario, also a goals, and then debriefing, how you feel after. This is some kind of first phase. If we're talking about emotion, descriptive analysis and application, but I will explain in next slides a couple things about it. Once again, session strategy, pre-briefing, goals, roles, environment, dummy preparation, because also this is some very important things. For example, if I wanna create scenario with some kind of stroke or intracranial pressure, and one of the symptoms will be one pupil. I want to show my student that will be like white without construction, and probably there is some problem on that side in the head, in the brain. And I will not explain my student that in high fidelity scenario, you need to take the light and check the pupil's reaction. And they didn't know about it, or they will not use that equipment because we not explain the possibilities of our human patient simulator. In debriefing, when I will ask my students how you recognize, or did you check the pupils? Someone can tell me, yes, I check pupils like normal. And what you found? It was normal. And even that doesn't matter about like resulting scenario, but actually I just, if I not made proper pre-briefing on the beginning before we start scenario, and I not explained that we need to take the torch light, anything to check, the realistic will be lower. if they will really take and check in proper time and will confirm everything, this is more like in real life, and we need to focus on that. That's the dummy preparation part is also very important. Scenario, 10, 15 minutes, general, but in our experience, our longest scenario with me is Sebastian and Mateusz here, also from Poznan. They are cardiosurgeons. We create some big education program, and we started with in situ simulation in Poznan. Our first simulation outside of hospital was 4.5 hours, and we discussed like almost one day about it, but it was not enough for us, and our longest high fidelity scenario was 72 hours. We really spent with the dummy 72 hours. My role was first. I arrived with ALS dummy, prepare for cannulation into small county hospital around 80 kilometers from Poznan. And I spent with that dummy on ICU 24 hours. And I observed the whole team, how they work. That was like, the beginning was really difficult because the chief of that ICU asked me, he's my friend, are you kidding? You wanna put me into my bed in my ICU, the plastic dummy? Are you crazy? No, I wanna practice with you. And I give you all of the information. I will give you documentation. I will send you anything what you want, because we are prepared to show you the realistic, practical time, in proper time. And then after 24 hours, they inform Poznan and high-level clinic that they need the ECMO team to cannulate in the county hospital. And we transfer after our plastic dummy with ambulance to Poznan and spend next 48 hours to observe on cardiosurgeon department. And that was 72 hours. And it can be like that, but debriefing will be not exactly the same like what I will show you. If we're thinking about short scenario, 10, 15 minutes, usually feedback, it's like time when teacher, coach, moderator, facilitator, instructor talking more and giving the proper information. You made that, but you need to do something like this. And we're giving actually feedback in short couple words to summarize what exactly happens. We're asking students what they want to change, how they make that again, or how they want to like improve that. But and in that specific idea in feedback, it's like 80% will talk teacher, 20% will talk students. But if we want to use debriefing, actually this is some opposite. We want to create that students will discuss and we will ask them, and we want to know why they made something like that, why they use that way, why they create that pathway of that protocol, why they thought that that was their priorities. We want to know more about their performance and their perspective. 75% from students, from participants, and 20% from moderator or from instructor or teacher. On the beginning, usually after some scenario, high fidelity scenario, we should ask about initial impression, how that experience it was for them. What exactly happened? We need to talk about good things, like good side from their perspective, but this is like usually this is the most crucial moment, because we don't want to talk about our good side. If we finish scenario, probably you have some experience, maybe even more by me, but like if someone will ask us like, what do you made good? I forgot about it. No, sorry, stop. Tell me, what do you made good? It's difficult. I made, we made mistake. No, tell me what was good. I want that you will keep in your mind good things, not we will start from the bad sides. But this is problematic because in our clinical life, for example, if we have on ICU some resuscitation, and one of our team member is brand new in my team, a rookie guy, second day in work. And we just initiate high quality chest compression, ventilation, everything, drugs, like the ALS, advanced everything. And after that, doesn't matter. But even like actually the patient died, and we will not spend with that new guy couple of seconds, and we will not tell him your job, your work was good. Next time, I want that you will make once again the same things. The problem is because that person, if we will not give him feedback, he can think after, maybe they are afraid to tell me something bad. Maybe I need to change my work in the next time. And that people very often looking for new things, and they want to make something better, but actually they didn't know that he made good job. If we will tell him, or I will ask him like, how you feel, what was your, how that experience was for you. And then I will tell him, that was good job, and I want that next time when you will compress again, I want that you will make everything the same like today, because you was really good. Then that person will focus, okay, I know that I need to repeat everything the same, and maybe I will add something extra also in proper pathway. And this is very important to think about good things, about goodies. What would you like change or make different? This is a really interesting question because we want to know perspective of our participants. Then, how was your communication model? And we can talk about teamwork. At the end, usually this is some application for the future. That debriefing is a very strong tool to summarize any specific high fidelity scenario, but only if we have proper time of that. If we will create the safe environment for discussion, because what is important, what happened in Vegas will stay in Vegas. And if we're discussing in that part with different people actually in a team, very often they're afraid to talk about good and bad things. And if we will create safe environment for discussion, that will be much better. And it's good to tell, guys, don't worry, everything will stay here. Why we are here? Because we want to be better. We want to be better for our patient. We want to create better model of education. We want to prepare and create everything to be faster, better, and we're thinking about give them more safe for our patient. Emotion, how you feel after that experience. We can talk and we can spend like 2-3 minutes about only short dropping emotion. If something was really good, students will tell me. But if something was really bad, someone will give me, I'm afraid because. And it's good to like catch that pearl and discuss after a little about it. Like you told about that you feel not okay with something. Tell me why. And we can explain then and thinking about that in analysis phase. Descriptive phase, like emotion, 2-3 minutes only for dropping that bad energy or increase good power in that. Descriptive phase, it's very important to focus only on dry data and in chronological time describe what exactly happened step by step in our scenario. Why? This is 3 reasons. First reason, we have a team of people and they have different roles. And everyone will have usually some kind of tunnel vision, some kind of own responsibilities. If I will create some scenario and one person will focus on, for example, cannulation, then second person who is by ECMO device will not see exactly what the second person doing in that time. And we want, if we're thinking about learning objectives, we want to, in the descriptive phase, connect everything to be sure that everyone catch that all of the part in scenario. That was first reason. Second reason, if we using live streaming of our scenario and part of participants will be like team members and the second part of participants will watch in real time this scenario, they will very often not catch all details because this is some another different perspective. And the third reason, it's the teacher, instructor, technician, like everyone who is in a team of educators, maybe will not catch every details when we watching that scenario from side of the Venetian mirror or we watching on the screens. And we want to discuss sometimes what you exactly made in that moment. And this is the best time to describe that whole scenario. In analysis phase after that, we will talk about goals, we will talk about technical skills, and we will talk about non-technical skills. But we need to create some plan for that. Maybe for the beginning, I want to talk with you about the goals. What do you thinking? What was the goals of that scenario? And I'm waiting, usually I'm asking with open question. I want to know what my participants will tell me, not I don't want to start with the closed question or from like close information from my side. Very often I want to know what they will tell me actually on the beginning. If we're talking about technical, we will spend some time to analyze that everything what was like strong and not exactly strong point of every medical protocol. And then after, we can focus on non-technical skills. We can discuss about communication, teamwork, explanation, and everything what is here. And after that, this is some kind of application phase to create some take-home message perspective. What my students, what my participants would like to take with them for the future, for clinical life, but very often also for the next scenario, how they want to improve, what they want to remember from that things. If we will tell them, remember about it, this is important, they will catch for a couple days, maybe for 2 months. But if they will tell us, if I will ask someone like, Sebastian, what you will take with you to your home for the future, and he will tell me, and that will be his auto-reflection. The connection in the brain will be for a real longer time. And this is very, very important of that. In high fidelity scenario, when our students, participants working alone without teacher, without instructor, without any help, then they're creating autonomy because every decision is their own decision. If we creating debriefing, we want to create auto-reflection. Okay, ECMO simulation possibilities. We can make everything. We need only learning objectives, that's for the beginning. We need plan, and we need to think how we want to do it. Very often, some kind of simulators we building in our garage. This is some kind of homemade without any companies, because the practitioners, they will know what they actually want from simulation. And our first scenarios and our first simulation, actually we thought maybe we'll create some kind of small dummy and we'll discuss what do we need to do if we want to create good ECMO therapy. But in the same time, we knew that will be not the best pathway to educate with practical part. We need to do, we need to put, we need to spend time, we need to be tired, we need to create fatigue in our teams. And this is much, much better. Our first in situ simulation was used more than 30 person. That was like 2 teams, and also technicians, educators, family members of a patient, and many, many people more to create realistic story. One of this scenario when we created, and we created for in situ, we use the dummy for ALS with prepare for cannulation in shop mall, and we call for help. Some bystander, one of us, called for help, initiate CPR, and dispatcher sent normal ambulance for that situation. Our paramedics from Poznan, they didn't know so long as they've been really close by dummy. And suddenly they inform us, holy shit, this is a dummy. Yeah, it's true. But you need to do everything like in normal life. We will not check you, we're checking system. We want to check how we can make something better. Focus on normal job. They made a really good job in that day. And they spent 45 minutes. They use first auto pulse for mechanical chest compression, and then we transfer patient for a hospital. In a hospital, we spend like next 2.5 hours for cannulation and also for create decision about donation after cardiac death. And actually, that was like our first hour in situ. But everything what we've done here, it was like in simulation, and suddenly like we decide about what will happen in with the patient. I'm not sure why one slide's gone, but why we doing that simulation? Because we're thinking about 4 rules of high fidelity. One rule is like we want to educate. Second, we want to make some probing and check the new protocols. If we are not sure in our region, in our hospital, in our clinic, in our department, that something working, it's good to create in situ simulation for my people in my department. But what is important, I need to be sure that no one share with them that tomorrow morning will be some simulation case. Because fun is also needed. And some kind of idea when we will surprise our team members is also very important. We remember one situation in Poznan. We create some in situ simulation with cardiac arrest in toxicology department. And we talk with the chief of the department a couple days before that some Friday morning, it will be that our simulation patient. And we just arrived with the dummy, put on the floor, and informed that this is our colleague. He took too much pills. He wants suicide, and this is some kind of big problem. Could you help him? He was in a cardiac arrest. And we informed the chief of the department, please not share with anyone about resuscitation, about ALS, about anything. And she said, okay, I will not. And that day when we made that scenario, we saw that in every room was the book of ALS on the desk. Why? Because she's not sure what exactly it will be, but she said, please check the algorithms because someone want to check us. That was one goal, actually, because if we create, and that people spend some, even couple minutes to prepare again for advanced resuscitation, it's okay, because our patient will be much more safe. But it will be not realistic to check, to probe that they're working every time the same. Yeah, it's very, very important. That's education is one, probing is the second thing. Also, this is some kind of time to think how to change the protocols and prepare our teams to working better. That actually simulation, normal simulation in sim center, in clean environment, this is the best option for the beginning. But if we want to make some probing simulation, it's good to create simulation for with in situ, because all the time, if you can imagine, if I will invite someone from any department, come on, we have excellent sim center, we can practice, we can spend time, we can learn together, and we will prepare some scenario for you. All the time, they will come, and we need to spend time for pre-brief them. In that boxes, in that crash cart is that equipment. Here we're using that kind of defibrillator. We have that devices, and we need to spend a lot of time to explain. If I will spend more time for pre-briefing, the scenario will be much hyper-realistic. If we will not spend enough time to pre-brief, then scenario will be less hyper-realistic. But if I will take with me my dummy, the mannequin, the phantom, the simulator inside the clinic, there is no time for pre-briefing, because people where they working, they know where is equipment. They should know, and then maybe we can check them. And this is the idea. Please remember all the time, simulation, this is not the, first of all, easy way. This is difficult work very often and really hard. We need time. Very often we need some extra cash to organize it. But also we need people who have a lot of passion to make that education model. Because we can use a PowerPoint presentation like I'm today, but it's good to show on the dummies, like on our next workshops, we will practice on the dummies, cannulation or ECPR, for example. That's every time in education team, we have team of people, and together everyone achieves more. If we're thinking like in a team, that will be very good idea to create the best realistic scenario for us. Any question? Because that was the first part of that. Okay, 7 seconds gone. That's no question. Okay, thank you.
Hand over. Nice to meet you, everyone. And my name is Justyna Swol. I'm and in a lot of EuroELSO activities, and also for our SIO working group, it's simulation and artificial intelligence in extracorporeal devices. So continuing the presentation of Marek, I would like to present you just a template for the scenario. It's already done, so there are some items which are filled out. And this is, so we developed this template in our working group, and it will be released also very soon for the audience. But just so it's just hot off the press, and just see the items which we believe they are important to have in the scenario. So the template have different colors for each part of this scenario. And the first one, you need the brief description, and you need to define what you are going to do. Then learning objectives, like assessment of the patient, ECMO circuit, identify recirculation. So this scenario is dealing with heart failure, I suppose. And then next step will be the background story. So it's like SBAL. So you need to describe the situation, what was happened to the patient, what is the background, what is his previous history, and then what kind of assessment in this situation has been done. so what kind of cannulation, ECMO flow, all this needs to be done before you start the simulation. And everyone who is on the training team needs to be involved and needs to know about all the details. So lab tests will be added as a separate sheet. So this is a scenario direction. It means it's divided in as a steps. Like this one, it's about 15 minutes, and you also need to have the control about the time. So you cannot just run the time and let people do a half an hour because there will be no result of this scenario. So for this reason, you just need to define the development of the scenario, and then a scenario flow chart. It means all the steps which are included in the simulation. So it's like we defined previously assessment of the patient, assessment of the circuit, and then hemodynamic derangement, shock progression, and hemodynamic improvement. Because also the simulator mannequin wants to be saved, and he or she wants to survive. This is, as I previously mentioned, gasometry and lab tests. Also important to be defined previously, and people, because it's like a real life. So this is what we have in the clinical setting, and you may also take the real patient and input the data of the real patient into this scenario. So you don't need to reinvent the wheel and to develop something new. You just may take the data they identified from the patient, and some, of course, some CT scans or X-rays, then echo and other relevant investigations like this CT scan, and then additional information like about the different configuration or configuration change and other supplies. So there are interventions. So this is the red part. Then interventions are ECMO team related and prioritized. So you need to define what kind of priority they have and what happens if nothing has been done, and what happened if it's done. Because it's like an algorithm how the scenario is developing during the time flow. And of course, equipment and participants, what's needed at this time. It's like a clinical setting. It's the same. You have the patient, and at this time you also define, or you need to prepare the intubation. You need to prepare the cannulation. The same is for the simulation setting. So it's not new. It's not different. And last but not least, the briefing tool, which means what Marek was talking about, the feedback. Feedback is needed, feedback is welcome, and feedback is appreciated, and feedback is which developed the participants and which also give so much self-confidence, and this is why we also are performing the simulation. So this is the aim, and the results to improve the outcomes. So thank you so much for joining us at this presentation, and have fun with your simulations, and just improve the outcomes and do it for your patient. Thank you so much.